Welcome to this educational presentation from Professor Mohammadi's teaching archives. Today, we will discuss a practical and clinically oriented approach to gait disorders in children, focusing on common pitfalls and how to avoid them. The central message is that gait assessment should not begin with a test. It should begin with careful listening, thoughtful observation, and accurate localization. A child's gait may reflect musculoskeletal, neurological, developmental, systemic, or functional factors. When we approach gait in a structured way, we reduce diagnostic error and create a more meaningful management plan for the child and family. Next slide, please. When assessing a child with a gait concern, it is helpful to use a consistent reasoning pathway. First, we identify what can go wrong. Then we ask why that error happens. After that, we translate the risk into a practical action plan. Finally, we apply simple clinical habits that improve accuracy during an ordinary visit. This structure keeps the assessment clear and purposeful. It reminds us that every gait tells a story, and our role is to listen, observe, think, and act with clinical intention. Next slide, please. One of the most common pitfalls is taking an incomplete history. In gait disorders, the history often provides the first clue to localization. We need to know whether the gait problem began suddenly or gradually, whether it is progressive or intermittent, and whether it is associated with pain, weakness, numbness, falls, fatigue, or loss of function. Open-ended questions are essential. Families may describe subtle changes in school participation, endurance, confidence, or play that may not appear on a checklist. Reviewing previous records and understanding the child's baseline function can prevent both missed diagnoses and unnecessary investigations. Next slide. Another important pitfall is inadequate observation of gait. Gait is a dynamic clinical sign. A few hurried steps in a small examination room may not show the full pattern. Important features such as asymmetry, fatigue, variability, turning difficulty, compensatory movements, or use of assistive devices may be missed. The child should be observed from the front, back, and side. Whenever possible, observe walking barefoot and with shoes at a comfortable speed during turns and more than once. Good gait observation requires enough space, enough time, and careful attention. Some gait patterns provide valuable localization clues. A hemiplegic gait suggests unilateral weakness or spasticity. The affected leg may appear stiff with circumduction during the swing phase, reduced knee flexion, and reduced natural arm swing on the same side. Recognizing this pattern helps direct attention toward upper motor neuron pathways, corticospinal tract involvement, and conditions that produce asymmetrical motor impairment. The key is not just to name the gait pattern, but to connect it with the neurological examination and the clinical history. Next slide, please. A waddling gait has a broad-based, side-to-side quality. This pattern often reflects weakness of the hip girdle muscles, especially the gluteal muscles. The pelvis may drop during walking, and the trunk may sway to compensate. It is sometimes described as a duck-like walk. This observation should prompt careful assessment of proximal muscle strength, hip stability, functional abilities such as rising from the floor, and possible neuromuscular or orthopedic causes. Next slide, please. An ataxic gait is usually unsteady, poorly coordinated, and broad-based. The steps may be irregular and variable, and the child may look clumsy or unstable. This pattern can reflect cerebellar dysfunction, sensory loss, vestibular problems, medication effects, or other causes affecting balance and coordination. When ataxia is suspected, the gait observation should be paired with assessment of coordination, eye movements, speech, proprioception, reflexes, and other neurological signs. A third major pitfall is failing to perform a complete examination. It is tempting to focus only on the legs, but a gait abnormality may arise from the spine, hips, central nervous system, peripheral nerves, muscles, joints, vision, balance, or systemic illness. A complete examination should begin with general appearance, posture, and alignment, then proceed through neurological and musculoskeletal assessment. Compare both sides and document tone, power, reflexes, sensation, coordination, range of motion, and foot alignment. The goal is localization, not simply description. Next slide, please. Another common error is overlooking age-related normal variation. Young children do not walk like older children. Early gait may be wide-based, unsteady, and variable. Coordination improves gradually, and a more mature pattern usually develops later. Developmental charts and age-appropriate norms help us decide when reassurance is appropriate and when further assessment is needed. Clear explanation to caregivers is important because it reduces anxiety while maintaining vigilance for red flags. Next slide, please. Toddler gait has its own normal characteristics. Toddlers often walk with a broad base, short, quick steps, and their arms held out for balance. Mild out-toeing, bowing, flat-footed walking, and frequent falls may be part of normal development at this stage. The clinician's task is to distinguish expected immaturity from concerning features such as regression, asymmetry, persistent pain, progressive weakness, marked delay, or loss of previously acquired skills. Next slide, please. A fifth pitfall is ordering tests too early or without a clear clinical question. Imaging, laboratory studies, and specialized investigations can be very useful, but they may also create cost, stress, incidental findings, and false positive results. Before ordering a test, we should ask, will this result change management? The best approach is to start with clinical suspicion. Use the least invasive and most informative test first, and escalate only when the history and examination justify it. Investigation should be guided by localization, not by anxiety. Next slide, please. A sixth pitfall is ignoring functional impact and environment. A technically correct diagnosis may still fail the child if it does not address daily life. We need to understand how the gait problem affects school, play, mobility at home, community participation, safety, confidence, and caregiver burden. Ask what matters most to the child and family. The management plan should not only identify the gait pattern, it should help improve function, independence, participation, and quality of life. Next slide, please. The golden principles bring the entire approach together. Observe carefully, examine systematically, think broadly but localize wisely, investigate appropriately, involve the family and caregivers, reassess and follow up. Gait can change with growth, fatigue, treatment, orthotics, medications, surgery, or disease progression. Follow-up is therefore not an afterthought. It is part of accurate assessment and effective care. Next slide. Before closing the visit, it is helpful to ask a few practical questions. Have I understood the story? Have I observed the gait properly? Have I examined beyond the legs? Have I matched the findings to the child's age and development? Have I chosen investigations wisely? And have I built a plan around the child's real life? This checklist transforms common pitfalls into reliable clinical habits. Next slide. The take-home message is that careful history, focused examination, and appropriate investigation are the foundation of pediatric gait assessment. Every abnormal gait deserves a thoughtful explanation, but not every gait variation is disease. Our role is to recognize meaningful patterns, avoid common traps, and create a plan that helps the child function better in daily life. Your careful assessment can make a lifelong difference. Thanks for watching.